Good evening, everyone,
Good
and
evening.
welcome to the Cobb Institute monthly show, presented in partnership with our friends at blackdoctors.org. This evening, we have an important conversation on combat and community care at the crossroads of community mental health and military experiences. I am Dr. Doris Brown, past president of the National Medical Association, a medical oncologist, and a retired colonel in the U.S. Army Medical Corps, where I also had the privilege of leading critical medical research initiatives. Tonight's topic is especially meaningful in the month of May, a month when we commemorate Mental Health Awareness Month, observe Military Appreciation Month, and reflect on the sacrifices of our service members and their families on Memorial Day. It's a time to recognize both the visible and invisible cost of military service and the healing power of community. So before we begin, I want to honor the legacy of Dr. Deborah Montague Cobb, who the Cobb Institute is named after, and whose contributions still guide our mission today. Dr. Cobb was also a past president of the National Medical Association and served as a civilian advisor to the U.S. military. He was a vocal advocate for the Tuskegee Airmen. He played a pivotal role in advancing the desegregation of the armed forces and veterans' medical care. As a professor at Howard University, he mentored generations of Black physicians, many of whom went on to serve in the military and at VA hospitals across the country. I had the honor of meeting him as he interviewed me as an incoming medical student at the Howard University Medical School. Today, we explore how experiences in the military services intersect with mental and community health, how trauma, how post traumatic stress disorder, and healing are shaped by culture, service, and structural inequities. We also look at how these stories can inform more compassionate, effective models of care. So we will open it up for questions and comments later in the program. But first, let me introduce our distinguished guests. We are joined by Dr. Mallory Williams, a trauma surgeon and veteran of Operation Iraqi Freedom, who worked at the forefront of addressing violence and health equities in underserved communities. And we also have and welcome Dr. Ron Bailey, Chair of Psychiatry and Assistant Professor of Community Engagement at the Louisiana State University, where he worked to bridge academic medicine and real world mental health challenges. He too is a past president of the National Medical Association. Dr. Williams, we will begin with you, and I'll ask each of you just to give some brief introductory remarks about yourself, and then we'll go into our questions. But we will share a few words about what May observance mean to you, both professionally and personally. Dr. Williams.
Well, thank you so much, Dr. Brown. It's such a pleasure and a delight to join you this evening with Dr. Bailey and to hold this very important conversation about observance for our military veterans and still active members and acknowledging the need for us to uplift this notion of mental health in our community. I'm Mallory Williams. I'm chair of the Department of Trauma and Burn at the John H. Stroger Jr. Hospital. of Cook County. I try to say that long hospital name as much as I can because many of the people who are dear to me know that John Strozier was also an Alpha. I am a colonel in the United States Army Medical Corps in the Reserve. I've served in, as you mentioned, Operation Iraqi Freedom. I've served in Afghanistan, doing Operation Resolute Support and Operation Freedom Sentinel. And so I am very moved at this idea of appreciating our military for all the sacrifices that they have done. And, you know, when I think about whether it's rural America or whether it's urban America, and perhaps the limited or fewer options that some of our young people have who would then move into the military and the heroic job they do to uplift the nation, it is truly inspiring. When I think about globally, you know, we have 6% of our population which are veterans, about 16 million people. That used to be 22%. I mean, it used to be about 18% in 1980. So we are a smaller percent on whole of the U.S. population. But when I really look at those numbers, it it just demands that we do a closer observation. Only 1% of the veterans that are with us now are World War II veterans. We really don't have many World War One, if any World War One veterans from the Great War left. 4% Korea, 30% Vietnam. We're going to talk about PTSD and what that war meant, certainly for our young people returning. And then 43% Gulf War, which just shows you that as we live today, the word veteran, anywhere you go, in the airport, at the Walmart, you're going to meet young veterans, and they're going to be increasingly female. Okay, so this maleness that used to take on most of what it meant to be a veteran, no longer so. A lot of females who are in our community are also veteran. But one of the reasons why I really like to focus on military observance is because as a Black American, you know, it was really the place that first served as the arena by which we proved our dignity as a people to the nation. We were always a dignified, well-accomplished people, but certainly in the military was where it took a broader notoriety, whether it was the Harlem Hellfighters in World War I, or whether it was the Panthers or the Red Tails in World War II. We distinguished ourselves, and long before the civil rights movements that occurred in the 60s, in 1948, Harry Truman signed signed executive order integrating the military, and that really was the cornerstone for which the civil rights movement would begin, and those were the footmen for the civil rights movement. So I think when we acknowledge our military as an African American, it really is acknowledging so much more. I'll stop there, and I look forward to a great conversation with Dr. Bailey and yourself.
Thank you. And so I can see that those comments really tells us how important it is that we continue to observe military appreciation each May. So Dr. Bailey, would you like to add your introduction and comments?
Absolutely. I as well want to say thank you, Dr. Brown, and for including me today. The opportunity to share the stage of you and Dr. Williams, just two outstanding positions in the National Association and in the Cobb Institute activity. Really warms my heart. Let me give my appreciation to both of you and others who listen today for providing military service. Not having done so myself, I certainly have a remarkable amount of respect and admiration for those who have done so, especially I think on the medical side. And I brag a little bit, although I'm not military. I have a son that's a 2020 graduate of the Naval Academy, and I'm learning a lot vicariously through him about just what Mallory just pointed out. Not only the value of having a strong military and the importance that it provides, I think, in the pride in families for their offspring, like for my son, but also I think the value that the entire country increasingly has now and has had for some time for the African community, and we've actually all offered, I think, through military service, going back generations and multiple wars, as I think Dr. Williams, I think, points out very correctly and very astutely. Briefly, I'm the chair of psychiatry for 3 programs now. I was the NMA chair going back almost 20 years ago now, and I've chaired both at Meharry College for 7 years, at Wake Forest, and I came here in 2021. In addition, as you point out, I'm the assistant dean for what we previously called diversity, now we call community engagement. So tonight's activity really falls within my community engagement hat. Personally, the three of us have really always touched these issues of being involved in our community, whether it's going to a health fair, whether it's volunteering at a school, whether it's trying to be engaged, I think, in podcasts like this to produce education. Mallory and I both have been involved in the Alpha weekly podcast called the Social Initiative, which actually addresses information for healthcare, by members of our community, for members of our community, issues that I think have remarkable value going forward. People need trusted messengers, Dr. Brown, and they need to listen to persons who they believe in, trust, and are likely to move the needle somewhat in changing their behavior and how we eat, our diet, how we exercise, how we follow our doctor's regular recommendations for medication regimen, all things that I think African physicians through the National Medical Association and the Cobb Institute have had a remarkable value in producing over the years, and we should continue to do so going forward. So thanks again for having me tonight. Again, look forward to a conversation with yourself and Dr. Williams.
Thank you. And Dr. Bailey, because you are a practicing mental health expert, could you talk about the importance of mental health awareness and why more people are talking about mental health? Can that help those who are struggling with the challenges of mental health accept it more?
I certainly can. And briefly, I'd simply say it also warms my heart that increasingly we have these issues, I think, in a public domain. I grew up in Beaumont, Texas, a smaller town about 100 miles outside of Houston. And that city, like many other small cities or southern cities, have historically, due to stigma, unfortunately, ignored issues of brain health, whether it's neurology or psychiatry, I think to our detriment. And many individuals, because of clinical depression or bipolar disorder or more severe psychiatric illnesses like schizoaffective disorder or schizophrenia or other forms of difficulties like panic attacks and anxiety disorders, have very often not received optimal or even satisfactory health care, because very often if your brain isn't working correctly, it adversely impacts your ability to produce the engagement to reach you, to listen to your doctor, communication issues are clean, does literacy, and then the follow-up recommendations, I think, of your doctor going forward. So we play a valuable role, I think, in psychiatric care in ensuring that I think all aspects of medical care are followed. People pursue health care in a normative way, and also I think do so in such a fashion to lead toward, I think, optimized results. What psychiatrists should particularly do in augmenting and helping those who've been treated for cancer or heart disease or diabetes or stroke is to ensure that persons have a clear, conscious, and a confident approach to what they should do to provide, I think, the engagement at the family level and individual level to pursue, I think, optimize health outcomes. Those, I think, are issues that we should be striving for as African physicians, particularly for communities that have been historically under-resourced and disadvantaged when it comes to information and resources that are necessary for optimized care. Huge issues, I think, for us going forward. I think items, again, that we in our organization should promote, I think, very aggressively for the betterment of our community.
Thank you so much. Now let's switch a little bit, Dr. Williams, since you're a trauma surgeon and having experienced that in Iraqi freedom, I only attended Desert Storm, which wasn't very traumatic other than very hot and sandy. When we talk about trauma-informed care, can you give us some thoughts about the importance of that in terms of the general public understanding what trauma-informed care is and what we can do to help individuals to control and again, individuals and communities, helping them to look at this in a more positive light?
Yeah, absolutely. And thank you for the question. When we talk about a trauma-informed care approach, it's really shifting our focus and our blame, if we're to be honest, away from the victim of the trauma and really beginning to consider the wider sphere of forces that particular patient is subject to. And so we move from what's wrong with you to a what happened to you context. And in that, we begin to acknowledge a wider sphere of community that person exists in. And we also begin to, I think, allow for greater humanity in that person, right? As we care for that person's injuries, we don't make the injuries that person. And so, from the standpoint of the patient, right, we are not re traumatizing the patient with how we care for them in our questioning, with the assumptions that we make, with the influences that we surround them by. From the standpoint of the community, we are looking in a broader context at communities and that people live in, and really examining the forces that are within those communities. So, if poor lighting, if broken playgrounds, if no access to quality food or quality after school programs or part of those forces, we begin to acknowledge that and we begin to correct that as a way of getting at the source of the trauma. It could be something much more simpler. It could be someone who is falling in their home, okay, and we begin to look at the broader scope of what's going on in terms of that as well. So I just don't want to limit it to violent crime. It's a bigger, it could be a bigger swath of entities. I think it's important because at the end of the day, when we look at communities, um, to be quite honest with you, it forces us to deeply examine the franchise, the ballot, what we do when we go to vote, and the importance of going to vote. Okay. And what do candidates mean when they propose certain issues before communities? Um, Communities may need to have increased law enforcement. They may actually need that. But are those law enforcement going to be in a community advisement, community partnership, or is there another purpose that those law enforcement are going to be mobilized for? It forces us to examine what we vote for in the social and political context. And it also forces us to examine how we wish to see our community, right? Because the hospital, whether we want to acknowledge it or not, is really a reflection of the broader community, right? The nurses that work there, the respiratory therapists, the janitors who help us keep the place clean, the doctors who work there, they're coming from the broader community, maybe not the same community, but the broader community. And how we shape that sphere is reflective somewhat of what we see in the hospital. So if we really want trauma informed care and we want that broader consideration of what happened to an individual versus what's wrong with an individual, that has to be reflected in our politics. If it's not, we will never get there.
Thank you very much. Now, I know today we're seeing more and more communities and healthcare systems that are adopting that trauma informed care practices. And a few years ago, I think there were maybe 10,000 people that had been trained in that. And over the last 10 years, that number has risen to about 250,000. So, Dr. Bailey, what is trauma informed care, and can you point that out from a mental health perspective and where this approach has been very effective, if you have any examples that might represent the positive change that you're seeing in your community?
Absolutely. I think Dr. Williams hit it spot on. The reality is we should be, as physicians, more about the global picture of the entirety of the construct that leads to impaired outcomes and health adversity in our patients, as compared to singularly what the symptoms are that lead to particular diagnosis and a one vector, direct vector item toward treatment. I love the example. I give credit to a great Chicago, and I know Mallory's in Chicago today, Carl Bell was a long-term prominent psychiatrist in our community, and they were respected by many persons who came up after him, like myself. And he loved to tell a story that he had trained at Meharry Medical College in Nashville, and there was much more of a public health approach, even when you're in medical school, than an individualized approach. And I think this has a representation for emotional trauma-informed care. An example you often would give is if somebody came in, there was a child and had a rat bite, you treat it, dress it, antibiotics, bandages alike, what have you. But if 25 kids came in from the same apartment complex with rat bites, you or someone under your sphere should go to that place and find out the causation and try to find ways to address it and deal with it, kill the source of the problem. Clearly a public health mindset, but I think a good example of an emotionally based issue regarding patient-centered care. What's focused on individuals, not just why they came in for you that one day, but what are the totality of the issues that are adversely affecting them. I think another line of reasoning in this business, of course, is if you're in a neglectful or an emotionally traumatic circumstance, particularly for children and adolescents. Very difficult to go to school and focus or concentrate in school, or to get by with individual considerations if at home your basic needs of humanity are not being met. Of course, the younger the child, the more the risk that neglect, even more so than direct abuse, is the problem. But both, I think, fall up under the rubric of the issues regarding, I think, emotional trauma-based concern. So for us, trauma-informed care means that you understand where all those traumas are coming from. Again, as Dr. Williams, like, pointed out very correctly, and you try to do something about it as compared to solely send a person back out into the environment with the same external stressors. We also like to use the term social determinants of health. All the issues regarding housing and food or lack thereof, or food deserts, or violence, and those concerns that may globally have affected an individual, although one problem is why they actually come in. It's a huge issue for us, though, because I think that as we train, and educate young physicians and clinicians, I love this idea, Dr. Brown, that there are 250,000 people now trained in this metric as compared to a much smaller number, 10,000 a few decades ago. It's essential because very often these are the issues that are much more likely to lead to long-term progressive problems, more relapse, and we actually just kind of send the person back out into the environment that the same problem repetitively. We must, I think, get to the source of the problem. A trauma-informed approach helps us do so.
Thank you. For both of you, I know we take vital signs when patients come in and they're tending to ask certain questions. Is it important to maybe look at violence as another one of those vital signs that we need to ask our patients when they come in and we're doing that interview? Is that something that we should think about as being very important given the society and the things that we live in and face today? What are your thoughts? Dr. Williams, I'll start with you.
Yeah, absolutely. Let's continue with the trauma-informed care kind of line of discussion. If a young lady in her 20s to 30s comes in and she has injuries that are inconsistent with the mechanism that is being proposed, and some of those injuries involve her face, we know enough to begin to do a deeper interrogation about what may be going on in that young lady's life. A trauma-informed care approach would be to understand that needs to be done likely in the absence of any company she may have. Trauma-informed care approach would have you to understand that if, in fact, this is what we fear, which would be intimate partner violence, that the reason why many women will return to those environments that are harmful or because of financial reasons, one, because of close family ties, two, and because of the children still being in the environment and fear for their safety. And so, how you begin to approach that patient has to deal with the underlying things that continue to connect the patient to that environment. So, we talk about safe haven, we talk about having an understanding of who cares for the children and how provisions are provided and who watches the children and how they are being attended to in the absence of the young lady if there are children involved. And so we begin to connect a care plan that makes sense, not just for the injuries that she's showing up with, but for really beginning to extricate her from the situation and scenario and forces that have resulted in those injuries, such that she can remain free of those free of those injuries. And so you don't get there without a comfortability with asking people how are they existing in their private spaces and in their communities? Are they free from violence? And yes, your patients will be surprised that you cared enough to ask in some circumstances. But it's important. And it's not just home, it's school, it's church. Let me say that again. It's church. Let me say that one more time. It's church. In the places where you are expected to be free of assault and danger, do you feel that way? Is there a weapon in your home? How is that weapon cared for? Who is allowed access to that weapon? Is it locked up? Is it separate of the ammunition? All of these things should be a part of good care. And it's not just the primary care doctor's responsibility. Okay, if you with me in my trauma bay or in my trauma center, it's my responsibility to kind of go through those things with you and attend to those things.
Dr. Bailey, I know for pediatrics, there's some rules that you have to notify child services, child health services, et cetera. If it's an adult female, do you have that same responsibility? And are there rules that may differ from state to state as to what steps you would take?
I think that both answers are correct. I mean, clearly, we have a fiduciary responsibility as an advocate, a treating physician, when a patient is at dire risk of harm, not to send them back into that same environment and to notify. That's actually one of the, Tarasoff like, allowances that allows one to break confidentiality, for example. I think that the rules are stronger, if you will, for children. Neglect can be a causation for, I think, for action as compared solely to physical harm or direct physical abuse or IPV, as the Williams mentions. But I think that in all cases, I think the higher incidence of suspicion is warranted. We may be the one setting in which that individual has a chance to not only be prevented from being harmed, but to save their life. If you don't send them back home to a setting that's likely to be dangerous and at risk for them. I like to often share with non-psychiatrists that, in psychiatry, this is pretty easy because we regularly are trained during a 4-year residency program that when you discharge somebody from home, there's a sweep of the home for potential risk of violence, weapons, guns, knives, and things of that nature. So we understand that you send somebody back into an environment where you don't want there to be a higher risk of them being harmed or harming someone else with potential weapons. The reality is, though, I think that your question is timely, Dr. Brown. The reality is the world has changed. We're an increasingly violent substrate, I think, of a society that we live in. So probably all the time, all doctors should ask those questions, not only when someone has been discharged from a psychiatric hospital, when they stated verbally, I know there may be some risk in going home. In the past, I've been abused, I've been harmed, or I've been suicidal, homicidal, because of what happened in that setting. It's also true that when persons are suicidal, homicidal, and the like, the data is very clear that over half of the persons who are likely to be harmed have seen a physician, a doctor, a clinician at least, within 30 days in a professional setting. So you never know which setting is that going to be where you're going to be the one with a chance to prevent that difficulty from occurring. But it does show that we have an inclination, most human beings, before something violent happens to us, we go to the doctor. We just may not say to the doctor, this is what's going to happen to me tomorrow. So it's up to the doctor and the clinician to have, again, that very high expectation of risk, and to be, I think, much more so likely to over-engage for a protective model. I think those are the points that we should actually point out to, I think, all young clinicians that are training, and all of us who practice, I think, kind of going forward. I like your point, though, in regards to violence being the sixth vital sign. We should really think about it as part of your regular battery of questions you're going to ask every time you see every patient, because the risk of violence is so high. We would think of seeing someone and not getting a blood pressure or vital signs just to make sure that we're not missing something. The consideration of violence, I think, is every bit as important.
Thank you. So now let's switch a little bit to post-traumatic stress disorders. And we know it's very important that trauma-informed care really has its roots in the military, because the military developed this post-traumatic stress disorder in the 80s, I believe. And so our understanding of that is really how we would care for our military service members as well as veterans. So, Dr. Williams, can you share with us how you've seen this in the field and how it's changed over time, and how this knowledge that we have in the military can get transferred to civilian communities and helping military veterans, particularly those veterans that you see out on the street that have obviously had some trauma, but not yet in a treatment facility?
Yeah, I think that's a very important concept, Dr. Brown. Remember, I said when we began this conversation, 43% of veterans that are living today, that's 43% of the 16 million veterans in the country, will come from the Gulf War. And the PTSD rates within that cohort are high. And I shall never forget several episodes that I have had as a trauma surgeon working through PTSD symptoms in our patients. As long as we as humans have had war, it should be just baffling to anyone listening to this that we just coined the term post-traumatic stress disorder in 1980. I mean, we've been doing horrible things to one another as humans for a very long time, if not thousands of years. We called it shell shock in the Great War, World War I and World War II. We called it battle fatigue. And what my colleagues in psychiatry recognized is that 6 months after the exposure to battle, these things untreated were not getting better. And then they kind of got more nuanced in how they began to approach the syndrome. At the end of the day, it boils down to sometimes the things you have seen in war are so horrific that there are triggers in your everyday environment that will not allow for you to have peace of mind, peace of sleep, peace of daily living. And that can manifest in many different ways: disturbances in your sleep, dramatic anxiety, dreadful fear, and then the need to even self-medicate in some very severe scenarios. We know that our veterans need intensive psychotherapy to really get down to working through the emotions from where they began. We know they've seen horrific things. We know the tendency is by our veteran population is to want to continue to be the heroes that we acknowledge them as: strong, resilient, not necessarily needing to work on the mind. So how do we get veterans and how do we get anybody to come to help when they have PTSD? Because we know the same PTSD that you get when you're in Iraq or Afghanistan is the same PTSD you can get on the south side of Chicago, in some of the other urban areas, Memphis, New Orleans, dare I say, from being around high levels of intense violence. So I've got several manuscripts in the literature. It's not about me. It's about what the manuscripts clearly shows that African Americans are more likely to present with more acute symptoms of PTSD. We're not talking about veterans. We're talking about people who are coming into civilian hospitals with injuries. And so it's very important to understand that while we understand PTSD through the horrific consequences of war, it exists even with our civilian population from what they have seen. We know that up to 6 months after these hospitalizations for injuries and being seen to have PTSD, we have persistence of symptoms, including depression and anxiety, that need to go on to receive treatment in these patients. In the military, we have what's called a performance triad, and we talk about sleep, we talk about physical health, and we talk about nutrition. It's a way of framing what health looks like for everyday soldier. And I think it is such a good model that we should use it for everybody. How are you sleeping? How are you eating? And what has your physical activity been like over the last month or 90 days? And that is where we begin to empower patients to begin to work on themselves. Okay. Everybody can go for a walk and get their 7,000 to 10,000 steps in with a pedometer that's right on your cell phone. Everybody can calculate what you're eating and stay within a certain calorie range. And everybody can know how you slept last night and why you may not be sleeping the way you were 90 days ago. And if you're not, then that begins the ability for you to get health, because we know that those things equate to your performance. So if you are a car and you're not sleeping well, you're not going to run well. So therefore, you got to go get and seek help for that. That's the rubric that we put it into the military, but it's more complicated for our veterans, because 40,000 homeless people in this country are veterans. And homelessness itself can provoke signs and symptoms of PTSD. So you can get into a vicious cycle. And if you're homeless, you likely don't have access to effective health care. And so you can see how it spins around. And you don't have to be a veteran in this society to be homeless. If you don't believe that, take a trip to San Francisco one day, or any major city in this country. Okay, so homelessness is not just a veteran disease, although you will find a lot of veterans within that particular cohort. And so it's understanding what we're looking for in our performance triad that we should be evaluating on a daily, if not weekly basis. And then it's acknowledging that something's not right, and then having that relationship and trust with a healthcare system, a provider, okay, and that may not be a doctor. In fact, that healthcare provider may initially be a pastor, or it may initially be a nurse in your community, or someone else whom you trust, to then be a gateway to actually a closer examination of the symptoms that you're experiencing.
Thank you. Dr. Bailey, just following in that same train of thought, how can the community, from its perspective, help to deal with the PTSD that we're seeing in the community, even though they may be veterans and they have not yet gotten into care? The consequences, we all know, it's just overwhelming. So how can we look at it from a community perspective of being helpful and caring for, whether it's a veteran or a non-veteran that has PTSD?
Well, the psychiatrist, I certainly appreciate the consideration, Dr. Brown. The reality is, and listen to Dr. Williams's comments, I kind of wish that maybe we had mandatory military service for everyone, because the service people focus on what you do for the government, but I love what the government actually does for you. That discussion about nutrition and exercise and sleep is signature for all of us, and just to essentially take your own vital signs, so to speak, to look back over the last month. I think, as William said, over the last 3 to 6 months, and see how you're functioning goes a long way to helping all of us kind of stay on track and get our train back on the right track, kind of going forward. I love the idea, though, that not only is it what you do individually for yourself, which is what was mentioned earlier, but also what the community can do to help. And there's a lot that we can do to help. First and foremost, I think we have to hear the message that people are hurting. I think we all have heard this long-term axiom that hurt people hurt people. The reality is those who've been victimized and violated and neglected and abused are most likely to do so intentionally or non-intentionally to others. That very often that happens to those who we are close to, our own family, our own children, those that we're the caretaker of. And I think that's tragic. Others on the outside might say, well, that's not my business to be engaged in it. Perhaps we should prevent more harm and more neglect and more abuse from occurring to those who are most vulnerable. Even the elderly increasingly now are very vulnerable in those type of circumstances. Next, I think that community organizations go a long way toward meeting, I think, individual needs. All too often, it's easier for a person to go to their YMCA to play Little League baseball or their local church activity rather than going to a psychiatrist for a formal visit to share what the problems are that are bothering them. So I've always been a psychiatrist in general, because I'm a Black psychiatrist that stated wherever you can go, when a person has a therapeutic alliance and they believe in you and you trust in discussing what your considerations are with them, that's where you should go first. Because you have to, I think, have some degree of comfort, that there's an emotional safety in beginning. All too often people don't begin, and then they go down the hill or down the pathway of multiple complications and more problems. More drinking of alcohol, more alcoholism, more self-medication with drugs, be it marijuana, otherwise, more difficulties, I think, at the work and at the home and other institutions of areas of life, because we can't stop and say, this isn't working for me. Let me try to find a way to stop and turn and move in a different direction. And I need some help from somebody. What you always hope will happen is that once you reach out to a community engaged individual, it could be your pastor at your church, it could be your sibling or relative, it could be a long-term friend, that will be, I think, the vector, and that individual will help you move on for professional care if needed. Finally, I'd say that typically when a person does finally go for professional care, they go to the doctor that they actually trust. That may not be the psychiatrist. That may be their primary care doctor. If it's a woman, it may be their OBGYN, whatever the case may be. And that doctor needs to have a very high index of suspicion that more is going on here than the physical, that the emotional and psychological is equally impairing this person's ability to function. And they need to make sure that they create a safe landing spot for that individual to share what the concerns are and refer them on, I think, for more engaged professional care. All issues that I think the entire community gets some involvement in. But first of all, being willing to recognize and reach out to someone and say, it's okay to not be okay, and how can I help is a start.
Thank you. Now, I want to move a little bit to access to care. And even though we recognize and we take care of those patients that come in with physical ailments, how do you get the patients to really talk about what they are feeling from a mental or emotional standpoint? Because we know there's a stigma that's associated with mental health. And so, Dr. Bailey, I think I'll start with you this time. Can you speak about helping those patients to open up when they're troubled by their mental health disorder, and talking about it openly, just as they talk about their physical health?
Again, I think a timely and a consequential and a signature point, one that I think I and other psychs I've been working on for 30 years, we probably need to do better. We're trying our best, but there certainly are we've made some gains. I think first and foremost, the fact that in settings with their trusted messengers, those individuals will begin the issue that mental health matters is key. I love giving credit to the church that I don't attend regularly, but I would be involved when I was in Houston 20 years ago. One of the first Protestant churches that I was aware of in Houston that actually would welcome psychiatrists and other mental health professionals to come involved when they had a overall health fair. And they'd have depression screening right next door to the blood pressure screening and the cholesterol screening and the like. Monumentally important, because throughout my entire career, I was in med school in Galveston and the like, often you really couldn't get the psychiatric screening, and that was somehow taboo due to stigma, as you kind of point out. So that's a start. I think past the trusted messenger perspective is also key, that I think we lead with the question. You can't have a clinician, psychiatrist, or primary care doctor, or the non-MD clinician, social workers, psychologists, counselor, therapist, who's afraid to ask. If we are passive and we wait for the individual to share with us, it may never really come out. We should be the ones actively pursuing a consideration that there may be problems in person's lives, and we're here to hear about it. If not, it's not a problem. If so, tell me how you're doing in that area. So I think being a bit more assertive, if not aggressive, as a clinician, and asking these questions about how things are going emotionally, psychologically. Has there been, again, abuse or neglect or violence? Has there been some problems, some recent change, and how you cared for? It's key. We do have, I think, empirical data that makes it very clear that once that initial question is asked, they're often in the medical sense, like a PHQ-9 is um, a rating scale we actually like to use. If you hit 2 of 9 key items, and what most think you're asking about their medical concerns, then that sweeps you into asking more about the psychological concerns. That's a strategy to use to help them feel comfortable. Because at times, what a person will say is, "I didn't come here to talk about the psychiatry. I'm not crazy." And that's their way to give you a little bit of a pushback. But you can't fall victim to that if you're a clinician. You have to kind of give a little bit more positive and respectful, but push, I think, that may be exactly the area that you need to pursue.
Thank you. Dr. Williams, would you like to add to that?
Oh yes, it's not much, but certainly it's very well discussed by Dr. Bailey. How do you push is where I want to add. Allopathic medicine is premised on there being a comfortable distance between the doctor and the patient. And what I like to reflect on when I talk about the art of medicine is how many people get lost in that distance. Okay. You have to draw nigh, as the Bible says. You have to come close to patients emotionally to get them to open up to you with some of these issues. And part of that, for me personally, is quite frankly sharing my vulnerabilities. Because my job is to help the patient. My job is not, I'm not running for anything politically. So my job is to get individuals to feel comfortable with speaking to me such that I can maximize my impact upon their health. And I don't think we all read Barbara Bates. Okay, and we all read the other physical exam books. That wasn't in there. We can all agree. Okay, what's that art of making people feel comfortable, telling you that I'm seeing things that, Doc, I don't think are there. I'm not sleeping well, and I'm having problems focusing, and it all happened after Mama died 2 weeks, 3 weeks, a month ago. Whatever the emotional or real otherwise trauma may be. And we really do have to be more creative in getting our patients to talk to us. Now, there's a lot of good work on racial concordance between doctors and their patients, and what the significance of that and what that means, not only when it comes to compliance with diabetic and blood pressure medication, but when it actually comes to getting more complete physical exams from patients. I think there's something there, but quite frankly, I think there is something to actually telling patients you care about them and you want the best for them. That wasn't in Barbara Bates. But there's a lot there in saying, I know we haven't known each other for a long time, but I think it's important for you to know that I want the best for you. So as we begin to build this relationship between you and I, patient-physician relationship, let's start with the concrete and the brick, that I'm here to see you live your fullest, happiest life. And to do that, it's not just the physical components that I need to delve into. There's also some emotional components that I want for us to get to a place where we can feel very comfortable talking about those issues as well. And so it's a dialogue, probably much more frank of a dialogue than most clinicians are taught to have.
Thank you. And I know our time is almost running out, but I think the richness of our discussion is very important. The last part, it's really important to me, is about engaging in research activities. And so before I switch to questions, I would just like to have your thoughts, both of you, Dr. Williams and Dr. Bailey, on being a good listener, and how do you encourage patients to become engaged in research projects so that we can have the data that is necessary to move forward, to help overcome some of the stigma that's out there? So can you speak about influences and research participation, whether it is encouraged, particularly we do a lot of research about drugs, et cetera, but do we actually talk about any of the emotional areas to get them engaged in research from an observational standpoint or participatory standpoint?
Yeah, as chair of the Cobb, is vitally important that we touch on this. When we did our survey research partnering with Stanford at Howard University on the trauma service, we had amazing participation. And what that meant is that those studies were well represented in terms of minorities, so that the data was then relevant. And I believe, I didn't ask patients, but I believe that the reason that we had great participation were several elements. One, they were in a Black hospital. The people who were asking them to participate and enrolling them in these studies looked like them, shared a commonality in language and other things, and that was significant or important enough for them to consider it and say, yes, not all did, but many did. And finally, the physicians, the people who were caring for them, emulated them, came from communities like them, and treated them with a certain level of dignity and respect, such that they believed that it was in their best interest to also engage in the research. And I think those ingredients are just critical.
Dr. Bailey, would you like to?
I'd add, I think that it again remains, I think, a remarkably timely item, because so many of us have struggled, our organization have struggled with this such a long period of time. I guess my anecdotal response, Dr. Brown, would be that what I've grown over time, the sharing, is that early in my career, I read about the Framingham study. And many patients have not heard of Framingham. They don't know it's in Boston or 9 yards. And how shocked I was as a person at that point in my career. I'd already been in med school and I think residency training or what have you. And I thought when you did studies, they produced data that was valuable and valid. And I took a lot of pride in using information that I thought was so-called empirically based. But one of the things that Framingham taught us several decades ago, that if you didn't include women in heart studies, because you were doing it for the betterment of women and decrease the risk of them being exposed to agents that might have an adverse impact on them or to be pregnant, then later on down the line, the data that we garnered or gathered may not be as helpful in us determining what are the best recommendations to give to women of all ages to decrease their risk of dying of heart disease. And women, like men, die of heart disease is the number one cause of death in their lives. So to focus on pregnancy risk earlier at age 20 and 30 may actually have a deleterious effect on a person when they're 50 and 60. And they, like everybody else, may have a greater risk of an untimely death due to, I think, heart concerns. I found some traction with that over time in explaining individuals as an analogy, because others as well. And because of that, persons, I hope, would appreciate, with that example of others, that we all have a responsibility to be involved in research, not just for ourselves acutely, but for others in our community, others of our gender, others I think other kind of backgrounds we come from, because there's certain components about us that's very unique that somebody coming behind me, not just my children, although my children and grandchildren matter, but others as well, in my community and otherwise, may need to know information that doctors and researchers can only glean or garner by persons participating, I think, in these studies. That's one strategy. I think the other issue has also just been simply that as we talk about research and appreciate that one reason many persons don't engage in research is the unknown. They're not really sure why they don't want to do it, but something inside them tells them that it's potentially a risk of they being mistreated or they're being, fooled or tricked. And whether that's the issue of the Tuskegee study, the idea of being a guinea pig, the concept that someone has mistreated their ancestors, all issues that we have to, I think, address and discuss. Otherwise, it becomes a 600-pound gorilla in the living room that prevents persons from making a decision to be involved in clinical trials. When very often, I think that they otherwise, when faced, I think, with adequate and satisfactory and adequate information about what really is likely to occur and what are the metrics of how a process occurs, so they're not going to be mistreated, not going to be a guinea pig, so to speak. Perhaps we can get over the barriers that some may have, kind of as intangible barriers that decrease, I think, our participation over time. Very happy to hear Dr. Williams points out about this recent study and that group participation. That shows that some of these educational maneuvers are working. We should continue them.
Thank you. And I think we can use the COVID during the pandemic and how that information was out. We have to be aware of misinformation and disinformation, but I think having those trusted resources that we can go to and really having the conversation, being a good listener, we can advance reduce, I should say, the stigma that's related to mental health. There are a couple of comments in the comment box, and I know we have probably 3 minutes left to conclude our program. One area that sort of struck me, and that we talked about homelessness, and that was one of the comments. The other one was about sexual assault in the military and how it is impacting a lot of women active duty service members as well as veterans. Is there any brief comments that we can make relate to that or state, Dr. Williams, on?
Certainly. I think the first thing we have to say, as I'm a colonel in the United States Army Reserve Medical Corps, is to acknowledge the truth. And the truth is that the United States military has a problem with sexual assault as it relates to women. There's no long conversation that needs to stand in place of that statement. That is the truth. Second of all, we've undergone a comprehensive program called SHARP, which most military people have heard of and know, and it trains us to understand what uninvited behavior looks like. It trains us to understand what harassment is, and it trains us to understand what the military posture is on it overall. Having said that, if you carefully study the data from the implementation of that program to now, many people who look at that data would suggest the problem is still there and is just as pervasive. We as military personnel are a subset of the overall population. Our behaviors, whether it's alcoholism, whether it's sexual harassment, whether it's racism, whatever ism you want to point out that's in the major cohort, will also be reflected in those who wear our uniform. And the question is, how do we train that to a better effect? We are struggling in that area. We are still trying, and we are committed as leaders to get to a better place. We're not there now.
Thank you. Dr. Bailey, any final comments there?
Not much. I would just simply say I think it's refreshing to hear Dr. Williams' comments. I mean, both of the two, you have much more, on the ground, hands-on, tangible experience, I think, in those areas of leadership in the military. But I definitely heard loud and clear and appreciate his comment that these are nationalized societal problems. And the military, just like in different regions of the country where you may live or different colleges where you may attend, are subsets of the overall larger pie that we live in. To me, the issue, I think, of we talked a lot tonight about neglect and abuse. and a power control dynamic where one takes advantage of the power that they have, either they're in a leadership role or they're in a role where they actually are your boss or control your income or your ability to move forward in your professional career. Those settings very often lead to the power imbalance that we see in life for some time that all too often too many people are taking advantage of. It's disheartening that it happens, but I think very heartening that we hear people in leadership acknowledge that it happens. And I was also happy to hear that there are programs geared to work to address it. I can say similarly, I've been involved for the last year now here in New Orleans. We got a big contract to provide health care in the local jail, 1,600 young men in the jail setting or what have you. And the federal government now has a program called PRIA along that line. It's a similar issue to address sexual assault by and of people who are actually incarcerated in that setting, but also those who I think work in custody and leadership in those settings. Clearly, I think both can have a lot of the same problem as well. Similar, I think, analogy. We've got to talk about it, educate people about it, and provide the kind of resources necessary to help somebody kind of move away from a disadvantageous and violent circumstance when they're vulnerable.
Thank you so much. I think as we come to a close, it's really important for us to look at what are the actionable things that we can do to try to minimize some of the trauma that's associated with all of the conditions that you've talked about here. And you just brought up the violence while incarcerated and some of the trauma that's there, and we're beginning to get some data from that. We talked about the homelessness and how maybe homelessness does beget mental health, or is it mental health that begets homelessness? And so you get into that circular situation. But I think it's important for us to know that there are resources in the community, as well as practitioners that are available that we can talk to with good listening skills to help overcome some of the trauma that's related to the anxiety and the stress that's there as we work on minimizing the stigma that's around mental health. And certainly, May, it's mental health awareness, not only for women, but for all, as well as the appreciation for the military service members and what they have gone through, or what we have gone through, and helping us to move forward. I hesitate to say that as some of our services are being dismantled, I hope that we do not lose the continuity that is important and the resources that had been available that we could continue, particularly with not yet coming to grips with sexual assault in the military and how we are going to handle that in the future. Thank you both for joining us this evening. And if you have a final comment that you would like to make, I'll welcome it now.
I'll certainly say that it's been a pleasure joining you this evening. And the conversations that we've had are very important conversations for our community. Let me finally say that we're going to have a very important Cobb Symposium in Chicago coming up. It's going to be on artificial intelligence. And the thing that we all must understand is that you can only teach a computer from the data you have. If you're not represented in that data, then the computer will learn the wrong thing about you, okay? Or will be very ignorant as it relates to you. And so we're in a time of artificial intelligence where our representation in big data is more and more and more important, if not vital, to our existence and in the betterment of our health care. So these participation in studies, being represented in every aspects of the healthcare landscape, that includes mental health. People who have mental health issues overall have higher healthcare costs. That's why they are studied, particularly from the economic standpoint. But if you're not there, if we are not there as a collective, then our particular realities cannot be learned, no matter how great the computers are running those algorithms. So this is a major time for us to be represented. And I'll stop there.
Thank you. Dr. Bailey?
My comments will be brief. Similarly, I really enjoyed the discussion today. I thought that the questioning was so timely. It really addresses, I think, the balance between trauma and mental health or psychiatry. I think we are kind of we're kissing cousins in this business. All too often, many of the same antecedents to the problems we tend to have to address. And I sort of appreciated the fact that you get to share with the audience the reality that there are things we can do. I like audiences to feel empowered when I finish on these podcasts, that so there's not a blank slate and we're not knowing what we are trying to do. We do have empirical data. There are studies that have shown there are some strategies that work. I think people should feel not only empowered, but I think motivated to pursue effective strategies for themselves or their family members when they have mental health problems. That's what I encourage them to do, and recognize that I think there are many trusted providers interested and willing to help them with whatever their concerns really are. So thank you very much for having me today. Thank you, Dr. Williams, for your comments.
Thank you. And I'll just say again, as Dr. Williams has indicated, the Cobb Institute will have the artificial intelligence or augmented intelligence at the NMA convention in Chicago, July 19th through 23rd. And also during that time, we will talk about clinical trials with Project Impact 2.0. So we're bringing lots of data, lots of information, and we hope that the public will join us as we continue to be a resource of trusted professionals that are there to help and to engage our community to advance their health outcomes. I want to thank you all for this evening, and I'm sure this will play back on blackdoctors.org. Thank them for partnering with us to get these timely words out. Have a good evening.
Thank you.
Thanks.
Yes. Bye-bye.